So trigeminal neuralgia is one of the facial pain conditions, and it manifests along the three divisions of the trigeminal nerve, which is how the brain gets representation of the sensation in the face. So you have three divisions, one along the jaw, one along the cheek below the eye, and one above the eye and into the forehead. So the neuralgia can manifest in one or all three of these divisions. And it's described as one of the most painful pain conditions in existence. So it goes from the patient being quite comfortable to suddenly having multiple shocks of what we call lancinating, so as if the face is being pierced, or electrical shocks in the face. And there can be a run of those, and then it stops. And then there can be another run, and then it stops. So the description of that is paroxysmal. That's the term that doctors use for it. So it comes really strongly, and then it disappears completely, and then comes again. So it's important we tease it out. There are a lot of other facial pain conditions which are very similar, or are crucially, subtly different and respond to different treatments. So certainly the diagnosis of trigeminal neuralgia in the first place is a very important first step. So why it occurs, we don't yet know. In 50% of patients, approximately, there is a blood vessel pushing against the nerve just as it enters the brain. And our main operation for this is to create a bit of space and a bit of a buffer between the blood vessel and the nerve, so it's not pushing on the nerve anymore. But as I say, that occurs in only about 50% of patients. So the others aren't clearly understood. Multiple sclerosis can also produce trigeminal neuralgia, and that can be from changes within the nerve, but also changes within the brain. In terms of what's happening to manifest this horrible pain, it's thought that there's a jump of electricity along the nerve in an uncontrolled fashion, just at the point where it reaches the brain, where you change from the wrappings around the peripheral nerves that go into the face to the wrappings around the nerves of the brain. So that interface is a point of potential weakness and a point of electrical chaos. So that's the prevailing theory. In terms of actually triggering it, for someone who already has trigeminal neuralgia, there are multiple different triggers, but they tend to be quite classic. So touching the face, cold wind against the face, chewing, brushing the teeth, cold drinks. So the most important treatment is medication. So carbamazepine or Tegretol is the commonest medication, and it's one of the features that most diagnostically pure trigeminal neuralgias respond to this treatment. Other medications can be added to that if it's insufficient, or the patient has adverse effects from the Tegretol, which is limiting how much they can receive. In terms of when I come in, so the neurosurgical treatments, the reason for intervening is when the painkillers aren't doing enough and the pain is very intrusive and very frequent, or to increase the medications, the adverse effects that are created are not tolerable for the patient. So that's when our neurosurgical interventions are important. In terms of our neurosurgical options, there are three broad options. Number one is surgery, and that's at the base of the skull behind the ear, where we drill a small window in the skull and tease the blood vessel away from the base of the brain. That's called a micro, because it's under the microscope, vascular, because it's a blood vessel loop, decompression. We're taking the pressure off that nerve. That has the closest to cure rate, but of course it is an open operation that we do, and some patients would prefer to avoid open head surgery. Another option is gamma knife radiosurgery. So this is relatively younger than the microvascular decompression surgery. So it's pioneered in the 90s and the early 2000s. And gamma knife is a sophisticated form of radiation. And rather than the cancer treating radiotherapy, where a whole wave of radiation goes over the brain, Gamma knife supplies multiple innocuous rays in different directions, and where they cross over is where they provide a noxious dose. So in that way, the brain can receive very little radiation, but the target, the trigeminal nerve, can receive a big dose of radiation. And the aim of that is to create changes within the nerve. So this leap of current is inhibited. So it's a day case procedure and entails applying a frame to the head. But otherwise, the gamma radiation you can't feel. So the actual treatment itself is painless after the frame's gone on. In terms of the outcomes, it's not quite as good as surgery, but it has a much lower risk profile. So although the risks of surgery are low in the current era, there's still an important risk of stroke or wound healing problems. With Gamma knife, it's incisionless. We don't open the head. The patient comes in on the morning and they've gone home by lunchtime. And you could call it a day case or even an outpatient procedure. They may have some headache for a couple of days afterwards when the frame comes off, but that settles down, and paracetamol is all they need to get through that ordinarily. And the important thing about Gamma knife is, whereas the surgery and other treatments such as through the face can give you instant improvement in the pain, we have to be a little bit patient with the Gamma knife effect. Because Gamma knife is more of a gentle treatment, it takes a little bit longer to have its full therapeutic profile reached. So it's about 1 month. Some patients can say the next day it gets better or within a week, but they tend to be the exception. It's usually about a month that patients notice to see an improvement. And I certainly don't make a judgment on whether the Gamma knife has worked for at least 3 to 6 months. So the changes that occur in the nerve are subtle and progressive, and it ramps up during that period.